Our final speaker for the conference is Dr. Jono Henry, coming to us from Melbourne. He's a Kiwi over in Melbourne that has a fascination with echo and ultrasound, and he's going to talk to us about his PELS project that he launches through South Pacific region. So welcome, Jono.
Thank you very much. People kept coming up to me and saying, "Oh, I feel so sorry for you that you're the last speaker," as if Casey's just left the dregs of your attention, but I prefer to think of it as an honor and a privilege. So how about we give a round of applause for the fantastic conference and the organizers, Casey, Kane. It's really been a special week. I want to start by just reading a quote from an American rabbi and author, Harold Kushner, who died 2 years ago. If I can get the clicker to work. Our souls are hungry for meaning, for the sense that we have figured out how to live so that our lives matter, so the world will at least be a little bit different for our having passed through it. Now, a confession, I guess, I would say on an average emergency department shift, sort of wading through, the access block and everything, I probably don't feel this feeling on a day-to-day basis. But something that has brought me this feeling in the last few years is our PERLS organization. Very topical, PERLS keep coming up today. A little bit of a tortured acronym, POCUS for Emergency and Acute Care in Resource Limited Settings. And thank you for listening to me talk about this for the next few minutes. Now, looking out at the audience today, there's probably a full spectrum of ultrasound fanaticism, from the barely users through to the full obsessives like myself. But I believe there's so many fantastic doctors out there who don't use ultrasound, who do brilliant work for their patients using all the resources that you have access to in your resource-rich setting, all your echocardiographers, your sonographers, CT, MRI, your intensivists upstairs, maybe. But hold that thought and put yourself in the shoes of doctors who work in these hospitals. So Vanuatu, Tonga, Samoa, and Kiribati. Some common themes in these, and these being the largest hospitals in the capital cities of these countries. Common themes would be the X-ray might be broken. CT probably not yet arrived in country, or maybe it's arriving, but again, frequently broken, hard to maintain. Sonographers would have some outdated machines, maybe some, their training might not be as comprehensive as sonographers at your local workplace here. Then take a step out into a more remote setting in the outer islands in places like these, and how few resources they have for investigation. Now imagine if you're a doctor in a place like that, if you had a device like this. So pictured here, the butterfly probe, just one of many fantastic devices. I don't have any relationship with any of the companies, but this happens to be the device that we predominantly use for our program. Currently up to its third generation device, plugs into a smartphone or a tablet. And as you would all know, we've figured out how to ultrasound everything from the scalp to the toenail by now, and has, we believe, really incredible capacity to image, most body organs. This is me way back in 2019. I spent 6 months as the sole emergency doctor at a hospital called Northern Provincial Hospital in Vanuatu. This was just when I finished my emergency training, and I took this Sonosite M Turbo. I could still sort of feel the strap cutting into my shoulder when I would get a call from the hospital. There's a sick patient. I grab the ultrasound machine, walk up the hill, and start investigating what's going on. And those 6 months, I really had a profound experience of the power of ultrasound when the resources around you might be really limited. Now, we've had a real masterclass in evidence this morning. Excuse me if I do a very brief skim over a few papers. I had my personal experience in Vanuatu, but there's some emerging literature about the use of ultrasound in resource-limited settings. If I can get my clicker to go. Feel free to move me on from there. So, the first paper, an urban ED in Ghana, the use of cardiopulmonary ultrasound for critically ill adults improved diagnostic accuracy from 57% to 72%, and there was an even larger effect size for cardiac diagnoses, and that was in Ghana. If you can click me to the next slide. In Rwanda, similarly, the use of ultrasound was found to impact what medications were administered and disposition in 42% and 30% of patients. So it's having meaningful clinical impact for patients. And next slide, please. These authors took it to the next step. So they conducted a systematic review of the use of ultrasound in low resource settings. They tried to find a mortality benefit. We all know how hard it can be to prove a mortality benefit for therapeutic interventions, let alone investigations, and here they were not able to prove a mortality benefit. Regardless, we believe it's a useful, important intervention. So these authors looked into what are some key best practice recommendations for how to conduct this type of training. So they recommended a focus on hands-on training, low trainer to trainee ratio, online training options, use of local trainers, short and concise training manuals, continuous supervision, early and ongoing evaluation, and tele-mentoring. So with that in mind, we, of course, launched PEARLS. Back in 2022, just as Vanuatu opened its very strict COVID lockdown, we were one of the first courses to be fortunate to enter. And we ran our first ever PEARLS ED course. Up in the top left there's a group of us FACEMs, along with Joe McCann, the president of ASUM, also Dasim Haji, myself, and Mick Colleen. And we ran a course focused around the eFast scan with medical and trauma applications, along with some first trimester scanning and ultrasound-guided IV line. The course lasts 2 days, and importantly, we add a third day where we go into the hospital, we scan real patients, we start to understand the local health system. The next important step after conducting a course like this is post-course image review. The butterfly probes allow us to review, the scanners in Vanuatu, for example, are scanning, they press upload on their phone or tablet, and we are immediately able to see those images and provide educational feedback. So imagine you're one of the Australian faculty, you've come home, you're sitting on your smartphone on your couch, and you can see these images that are being obtained in Vanuatu. Click through, click on the image you want to look at. You see some free fluid in the right upper quadrant, and you're able to give some educational feedback, start a learning conversation, and continue the education that you started in person. There's also a more comprehensive QA process that you can follow if you're looking on your laptop screen like this. And of course, we find this to be really critical rather than just giving these single brief workshops to provide follow-up for the learners. So what type of things come through on the cloud? Everything you can imagine. Here we can see cardiac tamponade, which is something encountered really commonly in many Pacific Island settings, patients with TB in particular. A patient here with a dense pneumonia above the diaphragm on your left, and the liver on your right. LV systolic failure there, the parasternal short axis, that circular left ventricle dilated, contracting poorly. Here, an apical four-chamber view with that large right ventricle on your upper left. Another shot of some free fluid in the right upper quadrant. Here, a pleural effusion, that dark triangle down on the bottom left. Another really sick-looking left ventricle. And the learners branch out and start scanning everything. Here they've found some very sick-looking bowel. This one I had to rehearse the diagnosis, hematometricolpos. This is a young woman with an imperforate hymen who's got a blood-filled dilated uterus, and she was cured with a hymenectomy. And this doctor was able to diagnose that at the bedside. Rheumatic heart disease, really prevalent in so many settings that we go to teach in. Here you can see that anterior mitral valve leaflet, midway down the screen, going into that hockey sticking formation. And at the top of the screen, a dilated right ventricle, as evidence of that really advanced sequelae of a sick mitral valve. More free fluid. Another really tight mitral valve there, over on your right, going into that hockey sticking formation. So, that's the type of things that we see coming through the cloud. Since 2022, we've replicated this across 10 countries, training 180 clinicians, and through really generous support of many funding partners, distributed 52 probes. 56 faculty traveled to teach 19 courses, and these faculty come from a really diverse backgrounds: emergency, anesthesia, intensive care, GP, sonographers, of course, echocardiographers, even a radiologist. And over 2,000 studies come through on the cloud. And, just like all of us at home here in Australia, the scanning that you do on the ultrasound machine, only a very small proportion of it is often saved. So we believe there's been tens of thousands of studies performed with these probes. We've initiated a Train the Trainer program, 16 attendees so far. The thing I'd say we're most proud of so far, we have 8 Pacifica doctors who've taught on at least one course. Some of them will have taught 3 or 4 courses by the end of this year. So we're starting to get that local ownership, and they start to take over running this program in their own country. After launching PILS ED, we've added PILS Crit Care, which is more echo-focused, along with some lung, and that's partnering with ANZICS, the ICU community. Monthly online Zoom sessions, lectures, online image review, newsletter, and on the verge of launching our charity to provide a bit of a financial engine to what we're doing. We've also proud to have published our first research paper of our own. The name right at the end there, Lewis McLean, he's actually started his PhD. He's an intensivist from New South Wales. His PhD is on critical care echocardiography in resource-limited settings, and he's being supervised by Sam Ord. So I just wanted to really finish with a few personal reflections about the process of going through this in the last few years. 6 early lessons and some surprises. Feel free to click me through to the next slide. And it's come up slightly funny, but this is Pearl number 1. So I guess when I first started the program, I would have thought that I should go and hunt for the most experienced and wisest POCUS experts. You've got the POCUS novices on the left, and then the absolute professors and masters on the right. And what I've realized is that POCUS enthusiasts from the whole spectrum can be valuable as faculty on a course like this. If you think of younger people, maybe less competing commitments in their personal and professional life, they've also got a sort of tech savviness to them. I'm generalizing. That can help us overcome a lot of technical barriers when we try and conduct this in remote settings. And they've also recently experienced what it's like to be a learner, so they bring that too. So we like to have a really blended faculty from across the spectrum, and even bring in POCUS learners and start them on their educator journey early. Next slide, please. This is a little bit left field, but I came across a concept called future time slack bias. So you can imagine if I've been trying to grow this program, I need to spend a lot of time asking people for things or begging them for things. Future time slack bias is everyone in this room are, you're all busy doctors. We all seem to think our schedule's really full in the next 1 to 2 months, but in 5 or 6 months, my time's really going to free up, right? So I've realized I need to ask people to do something in 5 or 6 months, because then people really feel like they're just going to have this nirvana of free time. So yeah, watch out if I sort of approach you with that kind of request. Next slide, please. Emergency medicine is logically the sort of beating heart of POCUS practice, because we want time-critical answers on sick patients right now. And I did start growing this with a team of FACEMs. However, I realized that the more legs that I put on the chair of Pearls, the more anti-fragile and robust it would be. So by enlisting sonographers and ICU, we can make this thing a lot more robust. There's a few reasons for that. Of course, we've got the more diverse technical skill set that rounds out our faculty, but also, in a funny way, a lot of the global health work that occurs reaching out from Australia or New Zealand to the Pacific is quite siloed. So the obstetricians are doing their thing, the ED doctors are doing their thing, the gastroenterologists are doing their thing, but no one's really collaborating. If we, and so they've all created these individual networks. We are now able to go and jump on the ICU network if we're struggling to make inroads in country through the emergency medicine network, if that makes sense. So also it gives new funding options, things like that. I think that's been really valuable to diversify our faculty. Next slide, please. Now, before you all gasp in amazement at my graphic design skills, this was ChatGPT. And yes, I do know there's a fingernail missing on the index finger. But imagine, so I sort of think of each of the faculty as an orange, or half an orange. We've only got so much juice in the squeeze, right? And this faculty member has got to dedicate time for family work, and I'm trying to ask them to do a bit of volunteering for Pearls. I've learned to try and not overstretch people, overextend people, because there's only so much juice in the orange. And I've learned to respect people's limits, I guess, over time. The other thing is that so many POCUS faculty are doing such fantastic work in their paid employment or other extracurricular activities, and all of that can flow, all of that expertise and knowledge then can flow into Pearls. So I accept the small, medium, or large amount of time that our volunteers can commit to. Next slide, please. The power of one. Over and over again, as we've grown, I've recognized that there's individuals who have made mammoth impacts on what we've done. The one that keeps coming to mind is a colleague of mine, Elise Pascoe. She was our ultrasound fellow at Frankston. Excuse me. And a couple of years ago, she committed to doing purely remote training of an ED physician called Donna Piamnock in Papua New Guinea. This was the first time we did any training in Papua New Guinea. And it was pretty taxing, the scheduling, trying to work with the technical limitations on that side, even just getting the Wi-Fi and data up, getting a Zoom call going, getting the probe out there, etc., etc. But she really persevered. A couple of years later, we've run a couple really big courses in Papua New Guinea. We've got multiple expert trainers on the ground there, and it's a really big, growing, flourishing program. So I often trace these things back to single people who've put their hand up and said, yep, I'll take responsibility to grow this thing. The last one, I am not a gardener, but I understand this is a bonsai tree. And as you can see, its growth is being limited by the tiny little pot that it's in. And I've reflected, what have been the real growth limiting steps for pearls? And it isn't necessarily what you'd expect. One major one has been technical limitations, so things like mobile networks, Wi-Fi in far-flung Pacific Islands. Also probes, use of the app, things like that, occasional probe malfunctions, trying to achieve maintenance. Probably the other big one that comes to mind again is that power of one. Just finding one person in Australia and New Zealand who says, yep, I am going to be the country lead for example, Vanuatu, and I'm going to just stick it out and really make it happen and go back there year after year. Places where we've had a really strong lead like that have really flourished. You would think that money would be a rate-limiting step, and, I'd be foolish to, of course, we would have loved to have had more money along the way. We would have had many more probes, but we've been successful in applying for grants. We've found funders who have bought into our vision, and we have been heavily reliant on faculty self-funding, flights, accommodation, time, really generously to go and teach on courses. Also recognizing that to get to our next stage of scaling up, funding will be critical. And on that theme, next slide please, this is really a mental note to myself that as we grow into the future, probably if I came back here in 3 years and I gave a similar talk, I bet that the learning points will be different. So what's got us here probably won't get us to the next level where we want to be. And with that, you can click me through to my last slide, please, and the next one. Thank you very much for listening. A special thanks to ACEM. They gave a really generous grant in 2024 for our work in Samoa and Solomons. Please, anyone interested, come have a chat with me, contact us, and I love talking about our project.